Hi, my name's Paula Nutting and I am a musculoskeletal therapist. I've also got a background in nursing in intensive care and a diploma in remedial massage, and I'm very excited to be presenting for the American Posture Institute for this virtual summit, and my topic is stress, chronic pain and the way out. An Australian survey done in 2015 indicated that anxiety symptoms were the highest that they have been, with 35% of people reporting having significant levels of stress in their lives. Now this is going up and not down, and we need to find ways to manage it. The volume of stress that we constantly live under has reflected on how our bodies respond to fright, flight and fight. When the body perceives that it's in a stress state, it will often refer to that common defensive position, and that is more like a fetal position that we commonly see in the clinics. Stressful postural positions will modify our phasic muscles to lengthen and weaken or lock long, and our postural muscles to shorten and strengthen or lock short. Now, in actual fact, that strength is a misnomer, because true strength should be out throughout the full range of a muscle movement, and these muscles will only appear strong in that shortest range, so they actually have stretch weakness. This shortening and defending of the postural muscles affects the joints of the hip and knee, the cervical region, and we especially see that in our common chin poke positions, our thorax and diaphragm, our shoulder girdle and arms, and our lumbar and sacral positions. We develop postural anomalies where we have low oxygen to the type 1 postural muscles, and they are dependent upon it. And there becomes a cycle of hormone imbalance, muscle misuse, lymphatic congestion, and compromised nervous system. Now, I find that using neurology to specifically target these oxygen-deprived muscles is part of a solution to reduce the likelihood of chronic pain. We adopt a treatment strategy that enlists neurofacilitation, muscle strength, and stress control. Now, our phasic muscles will actually take on dual roles when those postural muscles are compromised, and the musculoskeletal system will suffer. Most of these muscles are natural flexors, and that's evident in our upper and lower cross syndromes, as noted by Yander, but also in dysfunctions that can be seen throughout the body. And these can be mapped via our slings and our trains of muscle and fascial groups, and provide a really simple, reproducible system of treating and testing. Now, by improving these neural pathways, we can conversely affect the hormones that are released by the pituitary and the hypothalamus, and they're the ones that denote whether we're in fright and flight or rest and digest. And the benefits of stimulating these points will include motility of the lymph system and an increase in the action potential of muscles that will now then create strength, length, power, flexibility and endurance. As in osteopathy, the goal of facilitating these neurolymphatic points is actually not to directly relieve organic disease, but in fact what we're trying to do is improve the structural function and tone of the muscles. We're trying to relieve tension and restore the relaxation to the body. Stress. This is a term in psychology and biology. It refers to the consequence of the failure to respond adequately to mental, emotional, or physical demands. And the big ticket here is it's whether they're actual or imagined in the body. Now, when somebody perceives a threat, their nervous system responds by releasing a flood of stress hormones, including adrenaline and cortisol, and also those neuropeptides into the bloodstream. Now, what they do is the hormones rouse the body for emergency actions, and the stress response is the body's way of protecting that person. So when it's working properly, it actually helps us stay focused, energetic and alert. Psychologists define stress as how the body reacts to a stressor, whether it's real or imagined, and the control of stress is mediated by the autonomic nervous system, and it has 4 obvious stages, and a variety of acute stresses will affect the short term, where chronic stresses will affect you over the long term. I suppose what I really need to acknowledge that there's actually a first stage, and that's where we have absolute safety. This is where the state of parasympathetic system is the primary driver. i.e. that there's no stress and the body's feeling there's not 1 ounce of threat. And you can see this in my new grandson, young Hunter. It's mostly derived from the brainstem and inhibits the sympathetic nervous system by dampening the hypothalamus, pituitary and adrenal axis, otherwise known as the APA axis. And this actually reduces our inflammation. Our facial muscles will lose the ability to smile, perform specific ocular movements, and to hear certain pitches once we've lost that and gone into the first stage of stress. Now, this is relevant to us as therapists because the eyes have a significant impact on our suboccipital muscles due to the increased tonus and tension when we look up and the release of tension when looking down. A fixed gaze is a potential splint to the suboccipitals, reducing the pathological resting position of the atlas and axis. Rage or fear is that first stage, and this is primarily from the vagus system where we withdraw. Our blood pressure elevates, our heart rate increases, and the limbic system, which is closely aligned to the brain with the hypothalamus, will go into an alert protective mode, and it won't function at its optimal level and learning will diminish. The hypothalamus, which is in close situate to the limbic area, goes into what's called an orchestra mode, and that's whereby the hypothalamus dampens its interaction to the motor neurons, and they're responsible for change and support of movement. Now, with the reduction of that motor response over time, we see hypertonicity of muscles and stiffness to the fascia in response. When the threat or stressor is identified or realised, the body's stress response is in a state of alarm. During this stage, adrenaline will be produced in order to bring about our survival mechanisms, and that's commonly coined our fight or flight response. The resistance is a second stage, and that's generally within the HPA axis, and it's a survival mechanism. If this stage is extended, long-term damage may result. As the body's immune system becomes exhausted, the bodily functions become impaired, and that results in symptoms and conditions that include ulcers, depression, anxiety, diabetes, digestive disorders, reproductive disorders, even cardiovascular problems. With all these sympathetic system situations, the body will be depleted from its usual feel-good hormones that are produced by the parasympathetic nervous system structure, and that's quite often what we will see in our clinic. If that stressor persists, it becomes necessary to attempt some means of coping with that stress, and this is where our polyvagal theory or unmyelinated vegetative vagus nerve theory is thought to be initiated. The polyvagal theory was introduced in 1995 as a new perspective relating to autonomic function to behaviour. This perspective includes an appreciation of the nervous system as a system, that's specifically the autonomic nervous system, and the identification of neural circuits involved in the regulation of the autonomic state, and an interpretation of that autonomic reactivity as an adaptive process within the cortex or the context of our evolutionary history of our autonomic nervous system. It encourages a level of inquiry that challenges scientists to incorporate an integrative understanding of the role that neural mechanisms play in regulating our biobehavioural processes. We look at it as what's in the mind is in the body, and that the mind can have lasting effects on the defensive postural changes that we see in our clinic every day. Although the body begins to try to adapt to the strains and demands of the environment, the body cannot keep this up indefinitely, so its resources are gradually depleted. Exhaustion is the third and final stage of our gas model. It's a rudimentary system that acts out when the body believes it's actually defeated, and it is immobilizing and produces that vasovagal syncope, which means that there's a sudden drop in heart rate, a behavioural shutdown which inhibits that HPA axis, and therefore it lowers our cortisol and our adrenaline. Symptoms of conditioned emotional exhaustion can often be seen in post-traumatic stress disorders, and you can see that with hyperarousal, blackouts and flashbacks. And at this point, all of the body's resources have eventually depleted, and the body is unable to maintain normal function. Interestingly, that initial autonomic nervous system, the symptoms of sweating, raised heart rate, etc., will gradually reappear, and then that cycle is just reproduced again. And with all of this stress state behaviour, we see defensive patternings, and that's where our journey as therapists will start. This is a really interesting slide because what it does, it gives us a breakdown of how the body probably was designed to create safety and protection right back at the early stage of evolution. And when we look at it and break it down, you can see that the jaw muscles that we quite often see tight and clenched is actually there to tighten and prevent the mandible from being traumatically removed. So we're actually trying to keep survival of the fittest. Our pancreas will activate active rapid blood glucose, and that helps for pushing that energy that we actually need. And our digestive system will shut down because the sympathetic nervous system is trying to get the blood effectively out to the musculoskeletal system where it's needed more rapidly. What we see is that our reproductive system actually increases in its activity in the effort to fulfill our basic nature, but we become quite impotent in that the sex drive is actually produced. And an example of that, quite often you see that women who are at that pre-menses stage will quite often have twins. It's that stage where the body is trying to keep that reproductive continuation of the species. Our superficial fascia along the legs and our skeletal muscles will actually become quite tight and protective. And that's so that we reduce our injury and our potential of blood loss. And when you start seeing chronic clients coming into your clinic, that tightness can be noted by just taking them into, if you have them in supine and do a straight leg raise or just a hamstring length test, you will note quite significantly that those legs will feel very heavy, and I believe that that's a fascial weighting. We'll also notice that the sacrum will tuck under to protect the brain and the spinal cord. And we will have also the muscles that run along the spine, so the paravertebrals will also tighten and thicken as a response to protect the central nervous system and spinal cord. We have a rapid production of adrenaline via way of the adrenal glands, and that is to help us for fight and flight. And we also have a thyroid reduction in its output, and that's to try to keep the body cooler. And if you start looking and mapping back to the medical history of a lot of your patients and clients, you find that there are a lot more people who display chronic issues that actually also are on some kind of thyroxine medication. What we see is also an inaccurate or aggressive information to the central nervous system, so that adversely affects the endocrine, the limbic, and the musculoskeletal systems. We have impaired or overstimulated hypothalamus that reduces the quality of the parasympathetic nervous system as a hormone driver, and the hypothalamus is housed in the same area as the limbic system. Therefore, it alters the emotional state, and that's evident in how we see things appearing in the fascia. And a common fascial emotional state is quite often our SCMs, our deep neck flexors. If someone's in stress, you'll see that flare up around there. Public speaking is a perfect example. Poor joint proprioception leads to an imbalance of alignment of the joints and altered movements of muscle contractions, including those of the diaphragm. And that's quite important because that's what we look at for diaphragmatic work, is actually our relaxation response. That relaxation response is an integrated hypothalamic reaction in which a human being or animal experiences safety and a sense of nurturing. This results in decreased sympathetic nervous system activity, and that psychologically and physiologically is almost a mirror image of fright and flight response. We can achieve this state the quickest way through diaphragmatic breathing. And diaphragmatic breathing techniques offer a rapid way to engage the parasympathetic response, and this leads to the production of dopamine, serotonin, and the primary neurotransmitter acetylcholine. These hormones are responsible for ongoing mellow state of steady state activity, and it's a feeling of relaxation, often with a sense of contentment. Correct breathing means that the efficient gas exchange of oxygen. Correct deep breathing means the efficient gas exchange of oxygen, carbon dioxide and hemoglobin. And this is measured in the brain via the chemoreceptors, which also measure hydrogen in the bloodstream. Now, spontaneous respiration produces a rhythmic discharge of motor neurons, and these nerve impulses continuously assess our mineral and hormone levels in the bloodstream and the brain. The rate and depth of respiration are regulated by the chemoreceptors that measure our partial oxygen, our partial carbon dioxide and our hydrogen. And this is actually where 75% of our natural inspiration is done. Now, before we activate the diaphragm, we actually need to be aware of our posture of our spine. Now, the more upright you can get through your thoracic spine, the more you can open up your ability to breathe. And by correcting your position alone, you can increase and improve your oxygen intake by up to 1.5 litres per minute. And what I'd like you to do is think about that flexion-driven position. So this is a perfect example of a child that you'd see in public transport, or actually lots of adults in public transport. People that are actually working in front of computers, watching TVs. A lot of this is our both flexion driven with the neck forward, but also we have this closing down of our diaphragm through the anterior thoracic cage. Now, that average human head actually weighs 10 pounds in a neutral position, and then we move the ears further forward over the shoulders. We get this massive amount of extra torque along the neck muscles, especially the posterior and lateral ones, that are trying to improve the hold our head in space. What I'd like you to do is just, as an example, I want you to try to lean forward into this position similar to what Harry is doing. So get yourself right down into that forward position for me right now. And I want you to try to take 3 cleansing breaths. So keep your head forward, your thoracic cage into a deeper kyphosis, probably a bit of a pelvic tilt into posterior tilt. And really try to draw in some oxygen there for me. It's pretty hard, isn't it? Trying to take a deep cleansing breath in that position is almost impossible. And yet, how many people do we see naturally in society that are in that pose? Now what I'd like you to do is sit upright, bring your head back into a more neutral position by actually increasing the thoracic extension. So get yourself back into a more neutral spine, and I want you to focus on where your sternum is. So your sternum needs to be elevated rather than your shoulders pull backwards. So sternum up. Now take a few deep breaths for me. So can you feel that notable difference? You can actually diaphragmatically improve the quality of breath there. You don't need to be using those scalene muscles as much. You don't need to be using those pectoralis minor muscles. We can actually recruit much better quality breath, and in that instance, we find that that even just doing that in itself will help vastly with our clients and their treatment outcomes. Now, clinically, I find excellent results working with our neurolymphatic reflexes. And these are reflexes that are located in the lymphoid tissue within the fascia, and they are manifested in the acute stage by soreness or tenderness at the distal ends of the spinal nerves. The tenderness is due to hypercongestion of ganglioniform contractions in areas of lymphatic congestion and myofascial changes, and they are known as Chapman's reflex points. Now, these hypercongestions vary in size according to their location and to the proportion of the pathology present, which can be specific to a muscle or to an organ. These neurolymphatic points are used in applied kinesiology and are used for diagnosing the relationship between a weak muscle and the dysfunction within that muscle or its corresponding organ or gland or tissue. Now, they were actually coined after Frank Chapman, and Frank Chapman was an osteopath who discovered first the visceral component of these taut bands, and he mapped a lot with the actual organ pathology rather than musculoskeletal pathology. He died at quite a young age, so the neurolymphatic points were renamed Chapman's points in honour for Frank Chapman. Dr. Irvin Kaur links the points to specific facilitated spinal segments, and I note that the stimulation of the distal spinal nerves make a change to the strength, the length and the myofascial pain. To understand Chapman's reflexes, we must have knowledge of the autonomic nervous system, our endocrine system obviously, our embryological segmentation, which maps us back to our spinal segment information, and the fascia. And as well, we have to have a good link with the lymphatic system, and that's necessary to work out the pathways from the viscous or gland and associated lesions. Now, by stimulation of the receptor organ, both the afferent and efferent vessels draining the surrounding tissues will be affected. And this will also affect the entire lymph system of the area. These organs are easy to palpate because of the edema or congested localized discomfort in the area, and that was coined by Myron Beale. So latterly, Dr. George Goodhart, who was the founder of applied kinesiology, liked Frank Chapman's work and wondered if there was an association with specific organs and the glands. And in Goodhart's assessments, muscle testings were his primary focus. And the first correlation that Goodhart found was that the Chapman's neurolymphatic point, which affected the stomach when facilitated, also helped turn on the clavicular portion of the pectoralis muscle. And pretty much from there, Goodhart was able to correlate all of the other aberrant areas of Chapman's and correlate it to a relevant muscle. And this meant that each muscle had its own neurolymphatic point. The way I map this work that I treat with my clients is specifically looking at the effect of our body when it becomes that defensive fright and flight pose. So the treatment that I find most effective in my clinic is actually the type of clinical work that involves our, as I said, postural muscles, but our core. So we look at trying to strengthen the muscles that are involved in our hip flexion, hip extension, our lumbar support, our core, our diaphragm, and then up into our deep neck flexors, extensors, and also mapping down into the lower limb. In order to effect change to the chronic dysfunction, we need to improve the neural output to chronic common defense pattern muscles. And as I said, they do include the muscles that I've just spoken about, but also the anterior shoulder girdle, which is quite common that we see pathologies that are involved in imbalance of that area, and also the thoracic cage. And quite commonly, our sling, so our lateral sling, which will pick up the adductors, abductors of the hip and leg, and our contralateral quadratus lumborum and lateral trunk flexors. And also we look at our functional back line or our posterior back line, and that is quite heavily involved in our latissimus dorsi on one side and the contralateral gluteus maximus on the other. Although what we do see in our clinic is that people will come in with pseudo-sciatic pain or piriformis syndrome, and we spend a lot of time considering how we can treat that piriformis, but in actual fact, when you do the muscle strength testing, we find that there's a lot of congestion and weakness in the latissimus dorsi. So what I do is I have a look at first assessing the body in its whole for strength, and then providing the relevant facilitation of the neurolymphatic reflex arc. And we do that for about 30 seconds. What they found when they were originally doing the treatment for the neurolymphatic points, that much longer than 30 to 40 seconds actually dampened the capacity to work well. And this technique is actually vigorous and light because the region of congestion is usually very, very tender, and it's actually quite superficial in its level. So we're not trying to work really deeply, we're trying to flush and stimulate. And we're also actually thinking about, are we creating an inflammatory response or a stress state by working too deeply? because it's really important that we don't work to a depth that's going to increase our client's defence patterns because of stress involved. When we look at our lower cross syndrome, it's quite interesting to have a look at this slide because it's actually quite useful in how we treat clients. And within this modality, I look at the lower cross first after I've established whether the diaphragm is actually working efficiently. So we're going to be wary or note that our hip flexors, our psoas and our iliacus, are quite often stretched weak. So they're very strong in a specific area, but then they become very weak through end range. And when they are inhibited and tight, then our contralateral or our opposing muscle group, which is our gluteus maximus, will actually appear weak, and that maps into Yander's lower cross syndrome. So then we get hypertonic lumbar rectus spinae and weak rectus femoris and psoas. When the gluteus maximus is not firing efficiently, what we tend to see is an unstable pelvis starting to arise, and then we see the hamstrings provide resilient tensile force, and they're trying to do that to stop the pelvis going into further instability. So how many times are you treating clients with an unstable pelvis that are exhibiting tight hamstrings, when in actual fact we need to be correcting the strength to the gluteus maximus, the strength to the psoas, and thereby allow the hamstrings to relax. Let's assess the psoas for its strength and function. If it's weak, we will apply the Chapman's reflex point that's relevant to it. So we're going to take the leg up. Now externally rotate and take it out to about 15 to 30 degrees abduction, which means we're taking in the fibers of the psoas. Stabilize the opposite ilium. Patty, can you hold that leg up? Put your hand on the medial side of the tib-fib complex. Hold it there, don't let me push it down. Okay. So we can see that there's movement there. She should be strong, and also she's really contracting on the opposite side of the body, so they're all tics that say we need to facilitate. The facilitation points for the psoas are around the umbilicus. 2 lineal lines either side, but to be easy for the therapist, feel free to roll around the entire umbilicus. You're close and you're feeling for little tiny beads, which sometimes feel like beads of rice, grains of rice. Facilitating, sometimes they can feel a little uncomfortable. It's getting in line from Patty. Let's retest. Taking the leg up again, externally rotate, abductive between 15 to 30. Support, hold that leg up for me, don't let me push it down. And you can tell automatically that that's much stronger. Did you feel that, Patty? Yeah. So we've facilitated the neurolymphatic points for the psoas, and that's part of our need to strengthen the core. The gluteus maximus is another big, powerful muscle that we need to have strength, stability, and function. If that's not working for you, that big driver, the glute max, is going to create a lot of problems in the hip, pelvis, and back. So let's test this muscle group by bending the knee. Just pop your hand underneath the heel. Hold that leg down for me, Patty. Don't let me lift it up. Okay. So you can see there's a slight amount of movement with that. So when I'm pushing up, hold down for me. You can see that her hips are lifting slightly, which says she's pretty good, but we need to really work that muscle group and facilitate it. We're actually working down the outside of the vastus lateralis, not on the iliotibial band, but just prior to it. So I'm actually going to be working on the opposite side, because there's no point in doing that side for the camera, because we need to see what works. So I'm just using 2 thumbs and working over it.
The glute max is part of defensive pattern as well. So our defensive patterns we can treat in two ways. One is by just getting the glute max to work properly. Secondly is to go along the suboccipital ridge, and I can show you that in a moment. Okay, hold that leg down for me. And you can see there's a lot more strength there. I want to make it a little bit more stronger, so I'm going to show you that defensive point along the suboccipital ridge now.
Unfortunately, our time's got away from us, so I couldn't show you that second part of that video, but we're actually facilitating those neurolymphatic points for the defense patterns, and we've got Patty's gluteal contraction and isometric strength much stronger again. Thank you so much for spending the time listening and watching this presentation. I hope that you've gained a lot out of it, and if you want any more information, please go on to any of those links, and I'm happy to answer any questions that you possibly have. I'm Paula Nutting, and I'm coined as your musculoskeletal specialist.